like to take a moment to thank our funders. These are funders who support the work that's being done at Cochrane, our reviews, our training, our education, these webinars. So thank you very much to CIHR and the institutes that you see listed there on our screen. We'd also like to thank PAHO, the Pan American Health Organization, for the support that they give. They actually provide the license that allows us to use this software, and without their support, we wouldn't be able to conduct the webinars that we're doing. I'd like to send a special thank you to Luis Gabriel Cuervo, who's kind enough to take these videos, these recordings, and he creates the YouTube videos for us. Without his support, we wouldn't have that tremendous resource in our archives. So thank you very much to Luis Gabriel. So today's webinar is being presented by Jane Noyes. Thank you so much for presenting today, Jane. She's the Noreen Edwards Chair in Health Services Research and Child Health, and the lead convener of the Cochrane Qualitative and Implementation Methods Group. She's an honorary visiting professor in child health at the University College Dublin, and she's the editor of the Journal of Advanced Nursing. Jane's research specializes in child health and social care research and cost consequences. Jane's equally at home designing and leading RCTs, mixed method evaluations, and qualitative studies. She's also interested in methodology, including complex intervention development and qualitative and mixed method systematic review methodology. Thank you very much for joining us from England today, Jane. Please feel free to go ahead.
Great, thank you, Erin, and welcome everyone. Welcome to the Qualitative Evidence Synthesis and Cochrane Reviews webinar. We've had an absolutely unprecedented response to this webinar. I know that Erin received over 458 emails about this webinar, and I'm looking here, we've probably got about 167 people online at the moment, and that's absolutely amazing. So thank you for joining us. It gives us an indication of how important this topic is to systematic reviewers, and especially to those involved in the Cochrane collaboration. I'd like to say good morning, good lunchtime, good evening, or good night to those of you who are in Australia. We've had notification that some people are actually up in the middle of the night in Australia, so good day or good night to you, but please stay awake. And I'd especially like to say hello to colleagues from Bangor University who most likely are joining a Canadian Cochrane webinar for the first time. And several of you I can see on board already in the main room, so welcome. So we said that we'd look at qualitative evidence and synthesis in Cochrane Reviews. It's a very exciting time in the Cochrane collaboration to think about this. Some of you will know that we've actually had our first qualitative evidence synthesis integrated with a Cochrane intervention review published in the library, and that will be one of the sort of focus of my case study that I'm going to present today. So I'd like to thank very much the Canadian Cochrane Centre for inviting me, and I hope that the seminar is of interest to you. As always with Cochrane, you start with a conflict of interest statement, and luckily I have none, so I can move on from that. And if this is a global audience, I thought I'd better let you know where Bangor University is. So this is a map of the UK, and you can see that North Wales is highlighted, and Bangor University is there. You may well be aware that we have been hosting on Anglesey some royalty. Prince William and Kate Middleton, now the Duke and Duchess of Cambridge, have been living with us locally, and you can see a nice picture of Kate in the supermarket shopping. Luis Gabriel, sorry, I'm speaking too quickly, so I should say obrigado to you, welcome. I will slow down. I have a habit of going very quickly, I know. So I'll just sort of recap that this is where I'm based, this is where I'm speaking to you from, and it's an area that some of you might recognize from the press because we've been hosting Prince William and Kate Middleton, who've been living here for the last year. So let's move on. As Erin has said, please feel free to send in questions during the presentation. I'll address as many questions as we go along as time allows, but hopefully there'll be some time at the end. So please, and Erin will help me out if the questions get a bit too many, because with so many people dialing in, there might be quite a few questions to address. So I think the first thing that we need to establish is what counts as qualitative research. within this context, we have defined that a study is qualitative if it uses a qualitative method of data collection and analysis. So that would mean that interview studies that are primarily analysed quantitatively with numbers and questionnaire surveys with open-ended questions would be discounted, they would be excluded. So qualitative research is a study that uses a qualitative method of data collection and analysis. So here is an example of adolescent mothers' postpartum contraception use. It's a qualitative study. You can work that out because this is the abstract. It's a study with in-depth interviews, both of mothers, of other 18 key informants. So that's a qualitative method of data collection. So interviews, focus groups, non-participant observations are all qualitative methods of data collection. And the interviews explored behaviours, experiences, and then the method of analysis was content analysis used to identify key themes and patterns. So those are the classic things that you would look for in a qualitative study. Often it doesn't give you enough information in an abstract, so you have to look at the main paper. So all the qualitative research that I refer to today is going to be based on qualitative methods of data collection and analysis. So I hope everybody's clear on that. So let's start off with another poll just to see how you're doing with different types of systematic review methodologies. It will be really helpful to me to know what your experience is, and do you have experience, or what experience you have in different systematic review methodologies. So I'd like you to poll A, if you've only done quantitative effect reviews, B, if you've only done qualitative evidence syntheses, C, if you've only done a range of quantitative, qualitative or mixed method reviews, or D, if you haven't done any type of systematic review. So if you'd like to make your choice now, and please remember to not type your choice into the chat room, but if you can use your the icon, and I can see you voting now, that looks lovely. And Erin will quickly do the analysis for us in a minute when you've all voted. There we go. Okay, so that tells us, thank you Erin, moving that down a little bit, that mostly people haven't done any form of systematic review. Some of you have done some mixed method reviews. Interestingly, the smallest number have only done qualitative evidence synthesis, but most of you have done quantitative effect reviews. So that gives me a sort of an idea about how to sort of pitch the session and how much depth to go into. So thank you for that. Let's move on to the main presentation. So just a little bit of background history. This session is hosted by the Canadian Cochrane Centre, so it's interesting that a lot of the discourse or the conversation about qualitative evidence synthesis has come from colleagues in Canada. And I'm showing here a paper by Dave Holmes, who comes from Ottawa. He started a conversation and a dialogue in the international evidence base about how qualitative evidence was given not a great priority in terms of evidence synthesis. And I think it's very fair to say that Cochrane primarily developed methods for undertaking reviews of randomized controlled trials to determine effectiveness. And as Dave Holmes has written in his paper, not everybody was happy with the so-called dominance of the Cochrane effect review, and they felt that Cochrane was excluding other forms of very important evidence, such as qualitative evidence. Nor is colleagues, Dave Holmes and his colleagues, are particularly happy with the hierarchy of evidence that Cochrane produced in giving higher status to randomized controlled trials and other types of research. I think in Cochrane's defense, I think Cochrane has done a huge amount of excellent work in developing the methodology for synthesis of randomized controlled trials and pooling the effects of interventions, and obviously has produced the Cochrane Handbook, which has become the gold standard in terms of methods. Cochrane takes an evidence-based approach to any process, so has called upon the methods groups to make sure that the methods for any other type of method synthesis are robust before they include different types of evidence. But nonetheless, this article by Dave Holmes and the dialogue and the conversation that carried on afterwards was picked up in the British media in particular. This was published in the Guardian newspaper, which is a centre-left, very popular newspaper in England and Europe. It is available online. It's one of our main newspapers for health and social care. And in that newspaper there's a column called Bad Science. It's the journalist that manages it is Ben Goldacre. He's also a medical doctor. And he was highly critical of the article by Dave Holmes and colleagues. He felt that it was very harsh about the power and truth and fascism. You'll notice that if I go back, that the word fascism was mentioned in the piece that was published. And Ben Goldacre, you can see here what a character he is. He was very disturbed by this because he felt that Archie Cochrane was being called a fascist. And Archie Cochrane, of course, was the founder, or the Cochrane collaboration was founded on the sort of legacy of Archie Cochrane and his sort of need for knowledge and evidence synthesis to underpin decision making. And the fact that Archie Cochrane had fought against fascism in the Spanish Civil War, of course, really caused a lot of conversations to happen. Nonetheless, things have moved on in Cochrane, and one of the very positive things is the methods group that underpins all this work. And I would like to actually acknowledge the co-conveners of the Cochrane Qualitative and Implementation Methods Group. They're all listed here. I saw in particular Andrew Booth coming online, so I know Andrew and others are on board. So welcome, Andrew. If you can give us a little icon to say hello, that would be very nice. There's a little click there. Hello, thank you, Andrew. We have been working incredibly hard as a methods group to develop the methods and to support authors who would like to include a qualitative evidence synthesis. And I can just briefly show you some of the resources that we have. I would urge you to look at Chapter 20 in the Cochrane Handbook of Systematic Reviews of Interventions. We have developed a chapter on qualitative research and Cochrane Reviews, which will be updated in the next 12 months, but nonetheless is a good starting point, and do go and have a look at this. In addition, on our website, and you'll see that the website address is listed below, there's a series of supplemental handbook guidance. In particular, a number of additional chapters with more detail of the how-to undertake, some of the decisions that we had to make when going through the case study reviews that I'm going to present. And also we are available as a group of conveners to address your questions and support you if you want to do a qualitative evidence synthesis within a Cochrane context. Unfortunately, we don't have the resources to support people who want to do reviews outside of Cochrane at the moment. But do look at our website, and I hope that you find the guidance incredibly helpful. Again, it's a fast-moving field, so we're always having to run to catch up and update our guidance. And you will be seeing some new updated guidance of our PDF web-based guidance coming online fairly soon. So just watch the website for any developments. So when thinking about the key questions to consider when undertaking a qualitative synthesis, the first thing I think is why to do it and when to do it, then which methods to use, and then how to integrate the qualitative findings with the quantitative findings. And within a Cochrane context, there's a sort of a set of boundaries within which you need to make a decision. So in Cochrane, the qualitative evidence synthesis always needs to be linked with an effect review. At the moment, you can't go ahead and do an additional qualitative evidence synthesis unless there's either a title in the library already or a review, or you've got an intention to do a combined effect review with an additional qualitative evidence synthesis. So you need to be very careful about your decision making. You'll see here in terms of the case study that I've put at the bottom, the case study on the left is one review, which is the lay health workers in primary and community health care for maternal and child health and the management of infectious diseases. That effect review was led by Simon Lewin and colleagues and was already published in the Cochrane Library. And what we've added to it is a qualitative evidence synthesis of barriers and facilitators to the implementation of lay health or worker programs to improve access to maternal and child health, a qualitative evidence synthesis. And this combination of the two reviews that are then integrated in terms of their findings, this is a first for the Cochrane collaboration. So these two reviews mark a real milestone for the Cochrane collaboration and the Cochrane Library, and we're very proud of that fact. So in terms of setting the context, that's where we are at the moment, with one review in the library of an integrated review and a couple of others that have actually just have not quite achieved that as yet, and a list of protocols of works in progress. So I'm going to focus on these particular set of reviews as my case study, and I'm going to try and address these key questions with this case study as we go along. Okay. So when to undertake a synthesis of qualitative research, and I'd like to acknowledge Maggie Hendry for this slide. She produced the original of it, and Maggie Hendry is a colleague that's working on a Cochrane project at the moment and is a very experienced systematic reviewer. So hello Maggie again if you're online. So when to undertake a synthesis of qualitative research? Well, I think probably it depends on three related things. It depends on the review questions you want to ask, the team expertise and dynamics, and your time and resources. So if we take those one bit at a time, so it does depend on the review questions. That's absolutely fundamental. So if we just look at the sort of types of evidence that might be mapped again, the sort of types of questions that you want to ask. So the sorts of questions would be, does it work and what does it cost? So the sorts of evidence for that, that's your traditional Cochrane review of effectiveness and cost effectiveness. So your intervention studies and your outcome evaluations. So those are the direct questions that you would ask. But if you wanted to ask, how does the intervention work and how has it been implemented, in addition to how does it work and what does it cost, then the sorts of evidence that you might use might be process evaluations from trials or views and questionnaire surveys that might be linked to outcome evaluations. And for that you would use something like a thematic analysis and a narrative synthesis. If you wanted to ask the question, who needs it, you might want to do a synthesis of observational studies, and again you could do a meta-analysis or a narrative synthesis of that. And finally, the sort of acceptable and feasibility questions, those sorts of questions are most likely to be around qualitative research, to be addressed by qualitative research, that again might be linked to process evaluations. And you'd think of actually synthesizing those with a thematic qualitative synthesis. And then if you did more than one stream of evidence synthesis to answer more than one type of question, you'd then have to think about doing an overarching synthesis at the end in a Cochrane context. So I guess, you know, dependent on the review question, you'd then have to think about, well, does your team have the expertise and the dynamics to actually conduct these reviews? And you have to know your colleagues, you have to trust them, you have to know that you can work together. And I'll give you some examples of that in a minute. You clearly need the time and resources because the more streams of evidence and the more questions that you address, it takes longer and the review is more complicated. And certainly it's obviously much quicker to address the traditional Cochrane type of effect review without doing all of these supplemental reviews. But in the Cochrane collaboration, the review of the performance and the stakeholder engagement and the uses of evidence that was undertaken by the steering committee 2 years ago, our evidence users clearly said that they wanted more of this information to supplement the effect information and how much does it cost. So on that basis, we are selecting questions and reviews that it might be appropriate to add a qualitative synthesis. And we're going relatively slowly so that we can demonstrate the methods and the processes in a very evidence-based way. So let's just take some of those decisions to our case study material. And again, I would just like to acknowledge the team here, because of course behind this presentation there's a huge number of people. This is Maggie Hendry here, who isn't actually an author on the reviews, but she's working with us on some Cochrane-related projects. This is Jackie Chandler, who is the methods coordinator in the Cochrane collaboration. This is Miranda Laurent from Holland. She's the lead author on the nurse-doctor substitution quantitative effect review. This is Claire Denton from the Norwegian Knowledge Centre. She was the lead author on the qualitative evidence synthesis of the lay health worker review, and was also involved in the quantitative lay health worker review, and that was a great advantage. That's me, and when I look at this picture I just wish I wasn't wearing that skirt, because it looks like I've got the entire flower garden from home on my skirt. It's a bit colourful, isn't it? This is Simon Lewin. He's also from the Norwegian Knowledge Centre, and he was the lead author on the quantitative lay health worker review and also contributed to the qualitative component. So again, that was an incredible asset. And this is Arish Rashidian from Iran. He's also an honorary fellow here at Bangor University. And missing from the picture is Christopher Colvin from the MRC Centre and the University of Cape Town in South Africa. So we are a truly global team. Most of us knew each other, apart from we didn't know Miranda Laurent. And the WHO-funded systematic reviews, all that we were commissioned to do, needed to address maternal child health in association with the Millennium Development Goals. And we were asked to do a series of reviews in order to feed into a WHO guideline. So there was a very specific context here. So we were employed to do a specific number of reviews, not just the lay health worker reviews, but the nurse-doctor substitution review and a to and from midwife substitution review, which was a standalone review. So in the lay health worker review, this one here, we all knew each other and were joint authors across the two, and that meant that we could work very quickly together. We already knew each other, we already had a sort of a sense of a team, and we trusted each other. For the nurse-doctor substitution review, Miranda had already published the review in the Cochrane Library and was in the process of doing an update, and we went to her and said that we would like to do an additional qualitative evidence synthesis. And that meant that we then had to start putting into place legal agreements as to how we were going to work together, and our universities had to agree to it. And there were all sorts of intellectual property things that need to be agreed. And Miranda became a co-author on the qualitative component of the review that we were going to add to hers. So it's obviously, you know, when you're thinking about this, the existing team and who's published what is really, really important. And very important context to how you design your reviews and how you develop your titles. So in our specific context, our choice of design and method and our approach for integrating the qualitative and quantitative findings were determined very much by the style of review what was published already. And I'm going to focus now particularly and solely on these two reviews as the case study. That's the lay health worker review in primary and community care, the effect review, being supplemented by a barriers and facilitators to implementation of lay health worker program review. Because it was linked to and needed to feed into these WHO guidelines, we had a very defined timeline. We had we had to tie it to the Millennium Development Goals in relation to maternal child health. There was an existing frame of reference and belief system around the goals of the WHO. and the evidence needed to be produced and presented in a way that was understood by a guideline panel. So all of that had to sort of inform our decision making in terms of what we did in terms of the synthesis. So this is a sort of example of the things that we needed to produce the evidence for. If we go to the end product now, the WHO set a number of PICOs, so a number of review questions that they wanted addressing in the guideline. And this is one such PICO. Should lay health workers administer oxytocin to A, prevent, and B, treat postpartum hemorrhage using a standard syringe? And we had dozens and dozens of these PICOs or questions to address. So if we just look here, it goes through the problem statement. So the problem was poor access to prevention and treatment of postpartum hemorrhage. The option was lay health workers administering oxytocin using a standard syringe. The comparison was care delivered by other cadres or no care. So a cadre is a type of staff. So a nurse is one cadre, a nursing assistant is another cadre, a lay health worker is another cadre, a doctor would be another cadre. And the setting is community or primary healthcare settings in lower and middle income countries with poor access to health professionals. So alongside doing the reviews, we also developed the documentation called the DECIDE framework. And this is just a tiny section of the documentation that's about acceptability that links to the qualitative evidence that we're producing. So our synthesis of evidence had to be presented in such a way to the guideline panel, and the guideline panel had this particular form in front of them with all the effect data and the cost effect boxes above, and they then got down to acceptability. And they had to address the question, is the option acceptable to most stakeholders? And we would probably change these options now, but the options are no, probably no, uncertain, probably yes, and varies. We've now had some experience of using this with the guideline panel. And then further on here, we'd summarise all the evidence in this section here, and I'll show you what that looks like afterwards. So that's the sort of sense of what we had to produce, the product of the review. So in our guidance in the Cochrane website that we've produced in terms of the Cochrane Qualitative and Implementation Methods group, we've produced a flow diagram so that you can to help support your decision making in terms of the choice of methods. And the first thing is to say that your decision making would be different if you were outside of the Cochrane context. Inside of Cochrane, there will always be an effect review that needs to be achieved at the same time, or one that's published in the library. So if I just take you to the pink section here to start with, if you are outside Cochrane, there may be some methods and approaches that actually use a single approach or an integrated model, that you could integrate primarily integrate the qualitative and the quantitative evidence within a single approach. Now those sorts of approaches could include a realist review, a Bayesian synthesis, or a critical interpretive synthesis. But within a Cochrane context, these methods don't at present fit, so they're not methods that you can primarily choose from. Okay? So I'm going to focus on this side of the decision-making tool, so the yellow and the purple sides, right? And in choosing the method to incorporate an additional qualitative synthesis, you first need to decide what is the purpose of the additional qualitative synthesis. So if the additional purpose, or if the purpose that you set out at the beginning, is to interpret the synthesized qualitative evidence and develop an explanatory theory or models from the data, then that automatically leads you to think about undertaking or using a method such as a meta-ethnography or a thematic analysis with theory generation or a grounded theory. So these are all methods with detailed guidance that you can find elsewhere, and in our chapter in the handbook and our accessory supplemental guidance on the website, we give you the references as to where you'd go to for the methodological text here. Alright, so in our decision making with the lay health worker review, we weren't primarily setting out to do theory generation. So this particular route didn't apply. So we took this route here, and our primary purpose with our additional qualitative synthesis was to aggregate or to summarize or to integrate the qualitative data to address specific questions in relation to the Cochrane Intervention Review. And those specific questions were around the barriers and facilitators to implementing specific programs or interventions. So we went down this route. We actually selected to do a thematic analysis without developing theory in the qualitative synthesis, but a whole long list of other methods that we could have chosen here. These are just two examples, there are far more than this. Ours was a thematic analysis, and there's a whole range of thematic analysis that you can use. So I'll tell you a little bit more about that in a minute. And then the qualitative review product is a report with aggregated findings from source papers, but that aggregated qualitative review product then needs another synthesis with the Cochrane Intervention Review, which either is done through another process or has already been published in the library. So that's where we're at the moment. So we came down, just to recap, we came down this particular route. We chose a thematic analysis that then needed another synthesis with the Cochrane Intervention Review. So this is what we actually chose. So these are the selected methods for the lay health worker qualitative evidence synthesis. And I'm going to just take you through them. So we actually identified a theoretical model to help us. It was an implementation model called the SURE framework. This is an evidence-based implementation model developed to guide interpretation of implementation evidence by decision makers, and I'll show you what it looks like at the moment. And we wanted to use that as a theoretical model for it to inform the synthesis of the included studies. And because we were doing several reviews, we used the same theoretical framework across a lot of reviews so that we could actually then make some generalizations across a number of reviews. Our actual method of thematic synthesis, we use something called framework thematic synthesis, which is an adaptation of a primary method of qualitative data analysis, and I'll tell you a little bit more about that at the moment. So we've got a question here which I'll take now. Could theory not inform explanations of barriers and facilitators? I don't quite follow the distinction from theory generation to explanatory framework. So that's a really good question. How can I address this? You will see that we did go on to develop some theory, but we did it at the integration stage with the quantitative effect review. And again, we had very little time to do this review, so it was a matter of weeks and months. So our primary aim was not to develop theory. We needed to very quickly aggregate the codes and the themes from primary source papers in order to come up with some explanations. We weren't actually developing a theory of why the interventions didn't work, for example. All we needed to do was explain the barriers and the facilitators to the panel members, who then needed to make some decisions. Okay, so that would be my sort of initial distinction as to why we set out not to generate theory. But it's perfectly appropriate to have a framework, a theoretical model or a framework to inform your review, and I'll show you in a second how we actually used that as the framework that we used as part of the framework synthesis. Yes, Andrew, you're quite right, because we wanted to produce recommendations, yes. So we had to make recommendations to the guideline panel. Okay, what's the meaning of SURE and CASP? The SURE framework is the theoretical framework, and I'll show you what it looks like in a minute. I'll just come down the rest of the table, so I'll explain to everybody. So we've dealt with the SURE framework, and I'll come back to that. We used framework thematic synthesis, and I'll come back to that to show you the synthesis. because the WHO guideline was also a guideline for a global context, we were looking to include evidence from different global contexts. And so therefore we thought that it would be important to explore differences across different contexts. So we also incorporated some cross-case analysis. So therefore, the cross-case analysis we grouped studies into high, middle and low-income countries. So we could look to see whether there's any difference in evidence between the different contexts. Somebody just asked about CASP. The CASP is the Critical Appraisal Skills Program tool for appraising qualitative evidence. Again, you can find more details of that on our our Qualitative and Implementation Methods Group website. And we also used a new tool which we developed during this whole process called the CerQual tool, looking at the certainty of qualitative evidence. And there's more information in that as well that I'll provide for you afterwards. And then integrating the findings from the qualitative evidence synthesis to the intervention review, we used a logic model approach. And to go back to the questioner who said, did you not generate any theory? It was at this stage that we actually, once we'd finished our qualitative evidence synthesis, that we actually did a bit of theory generation to develop some hypotheses to link the qualitative and the quantitative outcomes. So where we didn't set out to develop theory, in the end we ended up doing it. Okay, let's move on because time's moving on. One of the questioners asked what the SURE framework looks like. I don't know what the acronym stands for, unfortunately. I think it's just called the SURE framework, that it helps you be sure about your decisions. But this is what the framework consists of. It talks about the factors affecting implementation at different levels of the health system. So it starts off with the recipients of care, the providers of care, other stakeholders, healthcare system constraints, and the social and political constraints. So by using the framework approach, these became the elements of our framework that we would actually look for in the data. And then the factors became the key codes that we actually coded the primary studies for. So in using this framework in framework synthesis, you develop what they call an a priori framework, in which case we took this one, and you apply this framework as your coding framework to the primary studies. So we took the primary studies and then we looked through the data, for example, for evidence of accessibility of care as one of the main factors affecting implementation. And we found this framework, with a little bit of adaptation, was incredibly useful. It allowed us to move quite quickly through the process of coding the primary studies, the findings in the primary studies. Now, I think it's also important to think about where framework synthesis sits in terms of epistemology. That's very important in terms of qualitative evidence synthesis. And I'd like to acknowledge here the work of Elaine Barnett-Page and James Thomas. The reference for this particular paper is at the end. And this particular paper actually has done a really nice study to bring out and show the dimensions of difference between the different methods that you can choose for qualitative evidence synthesis. So if you look here in terms of epistemologies, the epistemologies can range from idealistic through to realistic, and they're defined here. So subjective idealism means that there is no single shared reality independent of multiple alternative human constructions. So this might sound all very complicated, but if you're a qualitative researcher, this will all be quite familiar to you. Objective idealism, there is a world of collectively shared understandings. In critical realism, knowledge of reality is mediated by our perceptions and beliefs. In scientific realism, it is possible for knowledge to approximate closely to an external reality. And naive realism maintains that reality exists independently of human constructions and can be known directly. Now, even if you're not familiar with sort of epistemology of qualitative research, what Barnett, Page and Thomas have done has placed the common methodologies for qualitative evidence synthesis, such as meta-narrative, critical interpretive synthesis, meta-study, meta-ethnography, grounded theory, thematic synthesis, textual narrative synthesis, framework synthesis, and ecological triangulation, and others, they go on, onto this this continuum. And you'll see that framework synthesis, the one that we chose and selected, sits on the critical realism. So just to remind you, critical realism is that knowledge of reality is mediated by our perceptions and beliefs. And that actually was sort of fitted very nicely with the fact that we were using the SURE framework, that the WHO actually had a policy brief, that we were looking at the Millennium Development Goals, and that there was a whole sort of imperative for WHO and a belief system within WHO that implementation and evidence to inform the guideline was a sort of an evidence-based process. So that actually helped with our decision making in choosing a particular approach. Okay, so I think it's time that we actually got you to be involved a little bit again. So let's find out how you feel about undertaking an additional Cochrane qualitative evidence synthesis now. So I've been through some decision making that we went through, so I think what we'd like to know is what you're thinking. So get ready to poll again. Are you thinking it seems easy? That's A. B, it seems okay, but I need to phone a friend. C, panic, where on earth do I start? And D, never. So okay, I can see lots of responses coming in. Just give you a moment to finish making your choices. And again, please put your responses using the box, the decision box. Don't pop them in the chat room because we won't be able to count them. So Sonia Curry, one of my PhD students, I can just see that you put it in the chat room, so quickly make it a vote, please, Sonia. Let's have a look, and we'll just get the poll up in just a minute. Okay, let's have a look. Well, that's actually really encouraging in a way. Some of you say never. Yeah, not many of you say never. Some of you are panicking a bit, but not too many of you. It seems okay, but you need to phone a friend. And only a very few of you think that it seems easy. So I think that that's a fair representation. I think that that's fine. I think that a lot of people think that qualitative evidence synthesis is complicated, and I think that what this illustrates is that you do need a very experienced team and a qualitative researcher on board to do this. So I think the learning point from this is that if you are embarking on this, make sure that you've got some real expertise in your team and that you don't have to work all of this out for the first time. So okay, let's move on. So I'm going to sort of go through some of these processes quite quickly of what we did next. So in terms of searching, selection and quality appraisal of qualitative studies, I'm going to refer you back to the Glenton et al. Report in the Cochrane Library for the detailed report of the methods and processes. But in essence, we actually used a very good information scientist who designed the search for qualitative evidence, which is essential. We searched for qualitative studies related to included trials of the effect review that were related to them, which is important. And we searched for qualitative studies unrelated to trials in the effect review. And we adopted a sampling strategy to ensure a global spread and reach of qualitative evidence because this was a global guideline. And the review included over 50 qualitative studies that varied in quality and depth and richness and presented us with lots of challenges. But nonetheless, 50 studies is a large pool of evidence to work with. And we did actually sample, so there were far more studies that we could have included, but I'm not going to cover that today, and maybe that we can come back to that and do another webinar on sampling in qualitative evidence synthesis at another time. So let's have a look. We used, as I said, we used the SURE framework to code the primary studies, and that process is very much like primary qualitative analysis. You search or you read, reread and familiarize yourself with the primary studies that have been included. And then you attach the codes to the primary studies. You can either do that on the primary document, or you can copy the text out and put it in a software management product such as Atlas TI, or you can do it with a software product such as NVivo. If you're moving from coding of the studies mapped against the SURE framework to developing findings, the software product can actually help you group all the codes together, and then really a lot of the analysis happens in your head, which is why understanding and interrogating the data, you can use a software product, but actually it's the expertise of the team in interpreting this and looking at the data and understanding it and mapping it and producing charts is really the most important stage. And as a team, we spent a lot of time doing this. It was incredible the amount of time trying to understand the data and in its relative forms, the different contexts and how we put it together. It's difficult to explain how it happens, and I would sort of recommend that you become part of a team that is experienced so that you can gain the experience of doing this. But if I can show you some summary statements that we came out with. So this is an aspect of the SURE framework. So this is one of the things that the SURE framework encourages you to look at, which is program acceptability, appropriateness and feasibility. And this is from the recipient perspective, all right? So perspective in qualitative research is really, really important. The lay health worker recipient relationship became one of the important themes that came out. And these are some of the evidence statements that we produced. So Karen Daniels has just put in a question, sounds like grounded theory model building. In a way it was, but what we did was we actually managed the evidence as a whole body. So in grounded theory, you tend to start off with one study and then see if you can see the same things in another study and then another study. We actually coded all the studies together. We didn't do it sequentially to build a theory. So we started off with our theoretical framework, and then we applied that theoretical framework to every single study until we'd actually finished. So these are the sorts of statements that we came out with, as summary statements. So this would be one example. Both program recipients and lay health workers emphasize the importance of trust, respect, kindness and empathy in the lay health worker recipient relationship. Because this was evidence that was going to a guideline panel, we applied the CerQual criteria, which is about the certainty of evidence, and we graded it as being moderate certainty, and that meant that in general the studies were of moderate quality, and the finding, the synthesized finding, was seen across several studies and settings. Right? Let's just look at another example here. Recipients appreciate the similarities they saw between themselves and the lay health workers, and again that was moderate certainty. Okay, now Erin has just asked, is this CerQual similar to the grade system? That's an excellent question. Yes, it is. We developed this system based on grades specifically within a Cochrane context and whilst we were undertaking this review. And we're currently working with the grade working group, and if we do have time, which it doesn't look like that we will, I can, perhaps Erin might ask me back to do another session on CerQual, but yes, it is, to answer your question, it is based on grade. So let's move on. So if we were moving from detailed findings to key high-level findings and what you would tell the president in less than 2 minutes, these were the 8 key factors that help facilitate successful implementation of lay health workers. So because I've wanted to make this particular slide not too text dense, I've only included one statement here so you can have a look at. But in essence, this involved community connection, which meant selecting community health workers with local knowledge and from similar backgrounds to their patients. It meant incentives, introducing incentives that community health workers see as fair, consistent and appropriate. That meant participation, enabling families and communities to engage in deciding which health services will best meet their needs. Training, providing sufficient high quality and relevant training, including counselling and communication skills. Working conditions, ensuring a reasonable workload, manageable distances to cover, and adequate supplies. Integration, you'll see I've put the text here in, encouraging clinics and the broader health system to recognise and engage community health workers and nurses and other health professionals to develop better working relationships with them. Low or no cost services, and then communication and support. So that's what you'd tell the President with the key findings from the high-level findings from the review. But then we actually had to integrate these findings with the effect review, and we use chains of logic to do that. Now I know that Bridget Candy is on board, so Bridget, I know that you've also had interest in this sort of logic modelling. So let me just sort of explain for everybody. So in terms of the logic, we took a program component, so that could be something like their health worker selection. We then mapped the moderators, such as the recipients may not want to discuss sensitive topics, and the moderators might be the things that could be positive or negative in terms of moderating an outcome. And then we looked at intermediate outcomes, which might be something like the effect on good recipient relationship with the lay health worker, and then we took the longer term outcomes, which meant increased utilisation of services. So that was the sort of basic line of argument that we would sort of present. And this is the logic model, which I know is really busy, so I'm going to walk you through it very quickly. So in that, the messages to the President, I highlighted the integration of the lay health worker programme with other health workers. So this was the key evidence and where it came from. That the key line of argument and the evidence suggested that the lay health worker programme needed to be closely integrated. We were very clear, and we saw in the evidence that there were positive and negative moderators to the relationship. But if all the positive things were in place, there were increased referral from the lay health workers, there were better quality services and improved health outcomes. So that's the way that we actually sort of put the evidence together and presented it in logic models. This is the evidence as we presented it to the guideline panel. So you've seen this bit before, and you'll see here that we summarised all the evidence with the level of certainty, and we linked it to a qualitative summary of findings table. This is what it looked like in the published website in the guideline, with some very strong visual displays, which the guideline panel really, really liked. And very kindly, Metin Golometsu from the WHO wrote an editorial once this qualitative evidence synthesis was published in the Cochrane Library, and this is what he said. The findings of the qualitative evidence synthesis also usefully reduce the need to rely on the personal anecdotes and experience of the guideline panel members for issues of feasibility, acceptability and implementation. And I think this is a milestone as well, that when guideline panels only have effect evidence, then they chip in what they think that they know, and of course that isn't an evidence-based process. So a robust and a well-conducted qualitative evidence synthesis is actually really improving the decision-making by guideline panel members.
Jane?
And I'd like to just... Sorry, Erin.
Thank you. Sorry to interrupt you, but I know that we're reaching 1 o'clock, and I know that some people are going to have to leave. So I wondered if there are some questions that are unanswered in the chat room, whether you might be willing to send a written answer after the session?
Yeah, this is fine. I'm just on my last slide. Then we're on to questions.
Perfect. Thank you.
Is that okay? Yeah, so this is the last slide, everyone, and just to say that the Guardian newspaper picked this review up. So you'll see in your accompanying material that I've put this article in, that this big newspaper picked it up as a very, very important milestone for the Cochrane collaboration and WHO. And then over to any more questions. So Erin, over to you.
Thanks, Jane. First of all, can you just hit off on your microphone while I'm reading out some of these questions to you? Thank you kindly. Perfect. So we had a couple of questions going back a little bit regarding the how one would include, for example, open-ended questions. The question being, I would think that closed-ended questions would be excluded from models. Can you answer that question?
So that would be open-ended questions that would be in a questionnaire survey, for example. If that's the case, then we wouldn't count that as qualitative research, because the questionnaire survey wouldn't be a qualitative method of data collection. I think that needs to be clarified, because qualitative interviewing, of course, often includes open-ended questions. It's fundamental that there are open-ended questions and that the participant actually directs the conversation. So therefore, there's a distinction between a survey that's structured, that includes open-ended questions, which we wouldn't include, and a properly determined qualitative interview that would actually have open-ended questions.
Perfect. Thank you. We also had a question asking whether you could have just a qualitative study. Does it need to be linked somehow to a quantitative study?
We would, for this review, we included both. We looked for qualitative evidence that was attached to the intervention reviews, because that evidence is closest to the intervention and is likely to actually involve participants who are also trial participants. So that's a very good question. So it's linked evidence and is likely to reflect the actual experience of the person receiving the intervention. Nonetheless, we're also very interested in the general downstream experience once the interventions have been implemented and aren't linked to trials, or we're just interested in the general illness experience, etc. So there are two distinct types of evidence there, one that's related to the intervention and one that's unrelated to the intervention.
So that sort of feeds into another question that we had, asking whether you could further define observational studies. For example, could you do a qualitative synthesis from research that is focused on people's experience of illness or issues?
Yes, if I understand that explanation that you just gave. So an observational study might be participant or non-participant observation of engagement in field work. So you might be observing clinics, observing behaviours. There are proper ways of recording that. The more ethnographic and anthropological studies, for example, often include prolonged engagement in the field.
Thank you. Another question asked, when you say narrative synthesis and meta-analysis, does this mean that the qualitative data could only be used for the narrative synthesis, or that the qualitative data could also be used in a statistical meta-analysis?
In this circumstance, in the case study that I've given, the qualitative data was only used in the qualitative evidence synthesis, and then the findings from that qualitative evidence synthesis were combined to explain the quantitative outcomes. But if the person that asked that question goes back to the decision-making tree of what method to use, there are methods that qualitize quantitative data and quantify qualitative data, such as Bayesian analysis, and we're seeing things like constant comparative analysis, qualitative comparative analysis as well. So there are methods that can be used for that. We didn't use them. It wasn't appropriate in this Cochrane context.
Thank you. Can you address an appropriate critical appraisal tool that one would use for qualitative synthesis?
There are hundreds of them. We make some recommendations in our guidance on the Qualitative and Implementation Methods Group website. In this instance, we use the the Critical Appraisal Skills Program tool because all of us had used it. It may well be that different methodologies and different studies using different methodologies would require a different type of tool. Somebody's just saying, what about EpiReviewer 4? Yes, that's a tool that goes with Epi methodology. So have a look at our chapter in our on our website that gives you guidance on the tools.
Thanks very much. So there's a question from Mario asking whether there were different theories in ethnology that show different approaches for data collection, coding, and analysis. How would you manage that? So there's a question from Mario Tristan asking that there are different theories in ethnology that show different approaches for data collection, coding, and analysis. How would you manage that? Jane, if you can just hit talk on your microphone so that we can hear you.
Apologies. Sorry about that. It doesn't matter with the method of synthesis that we used. It was so flexible. You could accommodate any type of primary paper that had used any type of qualitative data collection and analysis, so it didn't matter. It was an approach that could accommodate any type of primary qualitative analysis.
Thank you. So there's a question asking for whether you can recommend reviews or methods papers of qualitative analysis for grade recommendations. And if it's okay with you, can I send that question to you for you to send a short list around?
Yes, that's fine. That's a very big question to answer.
Well, thank you. Another question is, were the studies appraised to be of lower quality weighted in some systematic way in the synthesis of findings?
We didn't weight the qualitative outcomes, but we put a sort of value judgment on the quality of the studies across the synthesized findings. So if the studies were very thin that contributed to a finding, that actually was reflected in the CerQual grading, whether it was high, medium, or low certainty.
Okay, thank you, Jane. We're definitely running over time. There's still a couple more questions, and I wonder whether perhaps those could be sent to you. Would you be comfortable with that?
Oh yes, absolutely, yes. It's been an interesting experience with nearly 180 people on board, because I was sort of primed to have about 50, so it's lovely to see everybody around.
Terrific, thank you. And Jane, may I provide your email address to everybody so that they could approach you directly?
Of course.
Perfect. Thank you. Then, my apologies to everybody. Again, it was a very exciting session with a lot of information that so many people have obviously been thinking about qualitative research and are really keen to learn more. So thank you very much to everybody for participating. I've just put a link to the chat room asking you to please complete an evaluation. The evaluation is really important to us, and it's something that indeed we do take into account. If you could complete those evaluations, we'd really appreciate it. And I'd like to ask everybody to please send a round of applause to Jane to thank her for her time today and for sharing her expertise with us.
And thank you
Jane,
very much for everybody for joining.
Terrific. So thank you to everybody. A reminder that we'll be sending around a copy of the slides to everybody who participated today and who signed in. So you'll have a copy of Jane's slides. You'll have a copy of the reference list that Jane provided before the session. We'll resend the evaluations, and we'll send a summary of the questions and the answers that came through the chat room today. So thank you very much, Jane. Really appreciate your time.
And thank you everybody for joining. It's been really great. Thank you.